and I'm going to spend the next maybe 30 minutes just discussing injuries in general, an approach to preventing them, and we'll talk a little about some of the work that our chapters do. So I have no financial relationships to disclose. I will say a lot of this work, besides the Ohio chapter really being supportive of it, we've also received some funding from local groups such as the Ohio Children's Hospital Association and the Ohio Children's Trust Fund, and then also we received some money from National Healthy Tomorrows grant. Next slide. So as I was saying, that really I want to spend today just talking about pediatric injuries and in particular infant mortality. We'll talk a little bit about some definitions. We'll talk a little bit about the impact and magnitude of the problem. Then we'll talk about some of the programs that the Ohio chapter is working on to address infant mortality. And then in particular, we're going to learn about pediatricians and how we can work together to cut down on pediatric injuries, in particular sleep-related injuries. And then we'll talk about kind of approach that we've been using and spreading throughout our state as well as nationally. Next slide. And these top stories are not just the only ones you hear. You hear the same stories every day on the news. So the first 10 minutes, it's very similar. You hear a child's found floating in their family pool. There was a fire and the children inside died. You hear about a car crash and the child wasn't properly restrained. And all the time you also hear families, and they'll interview them, and the family will say, boy, I wish that I only knew about this. Why hasn't anyone ever told me? And it's the same story day in and day out on the news, okay? So then many times people say, well, what is an injury? And so this is a long-winded definition that the National Committee for Injury Prevention and Control came out with, but it's any intentional or unintentional damage to the body from some external force. Right? And so when you think about infections, you have an organism that causes damage to the body. Really the way I look at injury is it's force that causes damage to the body. And it's either a force or it's some kind of absence, like an absence of oxygen or something that's going to affect you so quickly that there's really not much that you can do. The next slide. And then when we look at infant mortality, which many of you already know about, but, it's death of an infant before their first birthday. So it's the number of infants that die divided by the number of live births in a year times 1,000. And typically these are broken into two stages. You have the children that are under a month years of age, and these are about two-thirds of these infant deaths, and most commonly they're preterm births, birth defects, maternal health conditions, etc. And so I know that throughout our state a lot of organizations are working on trying to improve prenatal care for families, trying to improve preterm births. But then the other one is one-third of these deaths occur between really 28 days to 1 year of life, and the most common of these are what we call their sudden unexpected infant deaths, and most commonly they're either from some sort of injury. Either it's a safe sleep problem or it's a non-accidental trauma problem that is causing these later stage infant deaths. Next slide. So just let's look at the problem of injuries as a whole. And next slide. So if you take a look, this is the slide that most injury prevention experts kind of like to show. If you take a look at it, injuries cause more deaths than all diseases combined. It always fascinates me that the majority of my training in medical school and residency, I learned about all the infectious causes of croup, pertussis, meningitis, yet really did not receive very many lectures on injuries and the ways to prevent them. Especially if we were going to talk about, as Senator Jones said, prevention saves money on the back end. If injuries cause more morbidity and mortality than anything else, we should really be concentrating on ways that we could prevent these injuries to save monies later on. Just if you take a look on an annual basis, there are about 192,000 deaths annually, about one person every 3 minutes from an injury, about 2.5 million hospitalizations, 31 million ED visits, and it comes to about $671 billion in medical care and lost productivity. It's about 15% of all medical spending is the result of injuries and us caring for the injured child. Next slide. When you look at infant mortality, this is exactly what we were talking about before. You have the prematurity and birth anomalies care for the most common causes of these infant deaths, but then there's also the SUIDs or asphyxia, other undetermined, and now we're talking about a good one-third of these are things that we can actually affect, we can make a change on. Next slide. And then, again, when you start looking at these children under 1 year of age and these unintentional deaths, again, it's suffocation, it's non-accidental trauma, it's motor vehicles, it's drowning. All of these things that we can affect, and all we have to do is work on counseling and really making sure that our families know the best practices and actually practice the best practices. Next slide. And, this is the other slide, which I do like to show just when we're talking about injuries as a whole. People say, well, there's nothing we could do about it. Well, that's not really true. I mean, look at our international age-adjusted injury death rates. We are similar to countries like Nicaragua, Puerto Rico, but there are countries like England, Netherlands, Ireland, Australia, which are doing an incredible job at preventing injuries, and we're not even close to. We have to start working on ways that we can start reducing these injury deaths, and how do we go about doing it? And we'll talk more about that throughout the rest of this talk. Next slide. And I always like to say, C. Everett Koop, who was the Surgeon General of the United States, he always said if a disease were killing our children in the same proportions as injury, we'd be outraged and demand this killer be stopped. I mean, imagine if we came out today and we said, the Zika virus is going to come in and the number one cause of death to children is going to be from this virus. People would be outraged. They'd say, we need to find a way to stop this. Yeah, we have to start thinking about that for injury and how are we going to prevent these injuries. Next slide. So I'm going to spend the next 5-10 minutes just talking about some of the work that we're doing to work on the infant mortality problem and safe sleep issues as a chapter. And then towards the last 10 minutes, we're going to talk mainly about kind of the program that we want to introduce to all of you. All right, next slide. So the first one we've been working on is a statewide campaign. There's things that, although families know it, there has to be a consistent message that we always have to give. And so the safe sleep message is one that we've been working on. I don't know, many of you know that we've done a bicycle helmet campaign. Again, Senator Jones has been very supportive of this work. And, our idea is that although we can educate people about wearing a bicycle helmet, that education plus actually some legislative changes can really significantly increase helmet usage. So over the last 5 years, we've been doing a significant helmet campaign. And what's interesting is we've had a lot of recognition about helmets. We've been providing helmets throughout the state each year. We've been collecting some data, all of which we're starting to do now with infant mortality and safe sleep. Next slide. And really part of this campaign is there's not only media outreach through print and TV, but also where we've been making a lot of our strides is in social media by Facebook, Instagram. We've been working with organizations such as this organization and daycares. We've been doing some grassroots work with working with other organizations, and then also trying to work legislatively, which Senator Jones has really been the champion on this issue. Next slide. And then part of these initiatives, again, is make sure that we're all giving consistent messaging. So we have toolkits for educators, we have toolkits for legislators, toolkits for our partners. We've been giving away sleep sacks at some of our churches. We're giving away in our pediatrician's office, and we're going to start having some legislator events as well to really kind of make awareness about the sleep problem. And then, as I mentioned, that with our marketing campaign, we have paid and unpaid media. We've been handing out brochures that were developed through ODH's focus groups, dispersing sleep sacks, and then really working with our hospitals, our pediatricians. We'll talk about our hospital program next. Next slide. And then more recently, we've been conducting statewide surveys, especially in the high-risk zip code and county areas, really because although we can maybe screen for things of safe sleep, making sure that families are following the ABCs of safe sleep, there's really what message is going to work. So what we've been doing is collecting data from specific groups, and we're actually starting to develop some personas to determine which populations and which counties need which message. It was really interesting. I just went on one of these this past weekend, and a lot of families said, yeah, we know about the ABCs of safe sleep. And then when I would mention to them about co-sleeping, they said, oh, we're not supposed to do that. So they might have heard the tagline, ABCs of safe sleep, but they really didn't understand the specific message. And when they started to hear that message, they said, boy, I wish I had known that information. And so by the end of this year, we're hoping to have some specific personas of different populations and different counties to determine what messages work the best. The second program that we've been working on as a chapter is our hospital safe sleep program. So although many know about the recommendations for safe sleep, we don't always model the appropriate behaviors ourselves. We found that parents model behaviors that they observe, and so they're twice as likely to place a child supine at home if they witnessed it in the nursery. And hospitals really have this opportunity where they can provide education, identify resources, and demonstrate the appropriate behaviors. And children's hospitals in particular, as well as the birthing hospitals, are people think of us as the experts. And so if families see something going on there, it's what they're going to model in their home. Next slide. Unfortunately, when you look at the literature, only about 25% of observed infants are actually in the safe sleep environment. They've noticed that 20% of them are prone rather than supine. Close to 50% have multiple blankets. And neonatal nurses often place children in infants that are just supine rather, and so 50% are prone. If you take a look at this picture, this is just a picture of a child that was in the hospital setting. You can't even really see the child because there are so many blankets, there are toys, there are all these things that really are not part of the recommendation. And then despite practice not being right, they're also not even actually making the right recommendations. So only about 50% of neonatal nurses actually recommend supine at discharge, and only 30% of practitioners discuss safe sleep as a whole. Next slide. So we started this EASE program, which was we started in the hospital setting, and then we also took a look at it in the birthing hospitals in our next wave. The idea was to get really hospitalists on board, develop multidisciplinary teams of getting hospitalists, nurses, and administrators together, and we really wanted to increase the observed infants that are in AAP's recommended safe sleep location as well as in their environment. So we developed a standard screening tool, and then what we did was on this tool they made observations, and then we developed quality improvement work to try and work on finding infants observed in safe sleep behavior. This is just like one of the 8 QI programs that our chapter runs. Next slide. And what you could see was, which was really interesting, just because the quality improvement work really does make a difference, because it's putting in things that we know work, and then teams work to try and make that improvement. They have a common goal. So our common goal here was we started at really about 25% as a whole, and we got up to about 70% of infants observed in appropriate safe sleep behavior in just really a 7-month period. And what was really kind of fascinating was that we had hospitals that when policy was changed, which is similar to, within our state, once legislation gets enacted, that people start to recognize and say, boy, we have to start making a change. The other thing that was interesting was in our second wave, we looked at birthing hospitals along with children's hospitals, and a lot of the birthing hospitals had followed more accurate safe sleep recommendations, but what we found was that the birthing hospitals are modeling the right behaviors, but then it's dwindling as families go home, which is an opportune time then for the pediatrician to really be addressing safe sleep with their families. Next slide. So we put this program as an online program. If any of you are interested and you work in the hospital setting, you can do the EASE program and you can recommend it to the hospitals. They get 25 points of MOC4 credit, and it's a way to really make sure that the hospitals are following safe sleep recommendations so families will model that behavior at home. Next slide. And then the third program is, as you saw, unfortunately, non-accidental trauma is another cause of infant mortality. Just early on, and we use 2008 data, but it's still similar now. There's an estimated of 1,700 U.S. children die from abuse or neglect. It's a significantly high rate. And children under 1 are the main age group contributing to these child maltreatment fatalities. Most commonly is abusive head trauma, as many of you know, or they used to call it shaken baby as also. Next slide. And so we have our chapter has a child abuse action team, and this team meets and they really discuss from a child abuse perspective what are some of the best practices that they can put within their settings. We've been working with them on how best to screen and provide talking points for risks of child maltreatment, and that really many of them work with our child fatality teams so that they can actually go out to the scenes and see what some of the complications were so we can actually give recommendations later on. Next slide. And then, as I mentioned, so those are some programs that we are working on to address infant mortality. And then these last 10 minutes, I'm just going to talk about our injury prevention program, which addresses safe sleep, but it also addresses other injuries that might happen to children under 1 year of age. Next slide. So when I think of interventions for preventing injuries, we always talk about the 4 E's. There's engineering, which are usually the most successful because engineering works to develop product that will act usually as a barrier so that that force doesn't actually cause significant trauma to the child. That's how booster seats work. That's how airbags work, et cetera. There's also environmental modifications, giving safer places for children to play or act to get them out of harm's way. We've already talked about enforcement and legislation and how that works. But the 4th E is one that we often kind of talk about, but we don't really look at and figure out how best to do it. Really, that 4th E is through education, what our job should be is how do we screen for risk and then educate families and patients about the best practices. Next slide. So the first question is, well, who should be doing this? And, there really isn't a lot of literature out there of who is the best person to be educating about injuries. However, most families, even in the surveys we're doing now, as I talked to you this weekend, most families want to hear this from their pediatrician or their physician. We have found through Reach Out and Read and immunizations that really it's most effective if the physician is the one discussing, these recommendations. We do know that it's part of the job of the primary care provider. So if you look at the recommendations to the AAP and Bright Futures through the U.S. Prevention Task Force, really we should be addressing injury prevention as part of our well-child counseling. However, there's really no study to look at which provider is the most effective in providing this. However, I would say really any provider should be at least addressing this to some start. Next slide. We do know that, many would say, well, I don't even know if it works. Well, we do know it does work. There is literature to show that if you address injury prevention anticipatory guidance in a well-child care setting, that it increases knowledge or families' knowledge about injuries. They actually do make some behavior changes, and I'll show you some of the work that we've done that really reiterates some of this work that Bass and DiGiuseppe has done. And it does decrease injuries, and there's been some literature to show that falls and other home injuries as well as motor vehicle collision injuries are reduced when we address injury prevention and anticipatory guidance in the primary care setting. Next slide. Unfortunately, although it works, we consistently are not providing the appropriate counseling. So, there's literature to show that primary care providers don't provide injury prevention counseling. A lot of the reason is they don't receive the training. As I mentioned in my training that I received a lot of infectious disease training, but I did not receive a lot of training about prevention of injuries. So we don't receive the information in our training. We don't know enough about it. Therefore, we don't educate enough about it. The other problem is we don't have enough time. So I don't know if many of you remember, but in 2006, there was an article in Pediatrics, Drowning in a Sea of Advice, really, which talks about multiple policies that are written, yet we don't have the time to address all of them. So there are about 57 AAP policies with 192 directives, and two-thirds of these are injuries. And as you can see in this slide on the graph, that the purple is we continually come up with new policies, but we never take any of them away, and that's where the red line bar graph comes in. And so unfortunately, there's more and more for us to talk about, but how do we address all these in a short period? Many will say that we don't get reimbursed for this work, and so we only have so much time. How do I fit this in? How am I most efficient in being able to do this work? And some might even say, are we even hitting the right population in our primary care setting? Next slide. So we've taken a look. This was just, if you take a look on the right side, we did a survey about 3 years ago, and we just asked pediatricians in our state, well, are you addressing these kind of issues? And what was interesting, they said, well, 80% of the time we'll talk about sleep and car, but they weren't addressing poison prevention. They weren't addressing choking. They weren't really addressing water safety. So we really should be working at how do we address all possible injury risks for families so that they will all be informed and we won't hear those stories as we started this talk with that, oh, I wish I just knew. The other thing that was interesting about this survey was that 84% of these pediatricians said they, again, received no training or resources and weren't really sure how to address these issues. Next slide. Well, so many of you, if you've practiced as long as I have, remember the injury prevention program, which was the TIP program that was put out by the AAP. And what they had was it was an AAP policy statement about injuries. They gave safety counseling schedules, and they gave survey and information sheets. And what they were really nice that they did was they actually asked families of what their current practices were, and then based on their practices, people had discussions about it. One of the problems that occurred with these was that they cost money to produce because they were on a 3-ply rip-away sheet, and they also had very general information. They were talking about work of a 4-year-old prevention with families that were 1 year of age at the time because they had such wide age ranges. And so we said, these worked, but we need to make these a little bit better. Next slide. So we said, since these worked, how do we address injuries and make it more streamlined for the primary care provider? Next slide. So we decided, well, let's develop a new tool that would be similar to the TIP program. So we looked at statewide injuries. So Phyllis Agron, who's in California, she developed a study that was published in Pediatrics, and she looked at pediatric injuries at 3-month intervals. And that's how we kind of started with our program was how do we develop looking at what are the injuries occurring that are most consistent with developmental age as well as the ones that cause significant injury, those that cause ER visit or death, not just injuries that had minor injuries because we wanted to make sure we were addressing those that were most significant. We also looked at the Ohio Department of Health injury data, and then we also looked at recommendations from Bright Futures, from TIP, and AAP policies. Next slide. We partnered with national leaders that are experts within injury prevention, as well as local leaders that work with survey design or work with preventing injuries throughout the state. Next slide. And so we developed an injury prevention screening tool. And the purpose of this tool was to say, boy, we can actually address injuries by asking specific questions. And then based on the responses, we can actually talk to families. Initially, we had 6 separate tools, and those tools were for each well child visit. We found in our first wave that it was very difficult to keep up with the 6 tools, so we broke that down into 2 separate tools. We have a tool for birth through 4 months, a tool from 6 months to 1 year, and each tool has approximately about 20 questions and about 5 to 7 topics per tool. You can see the topics are listed below. Safe sleep is one of these topics, and we'll talk more about safe sleep because that's kind of one of the reasons for this talk today. Next slide. So in our first wave, we said, you know what, can we get this into practice very easily? And what was really interesting was, as I mentioned, we had 6 tools, but in the first month or 2, we found every practice was able to get these screening tools into place. But what we found that was really most interesting was, you remember the survey that we did that was really just we asked questions, and it was a little biased because it was self-reported. This actually, we looked at physician charts, and we saw that less than 50% of time was any injury prevention recommendation even addressed with families. However, after putting the tool into place and then after having families have discussions with pediatricians, more than 90% of the time was every injury prevention issue addressed. And just look at safe sleep in particular, we went from only 48% of the time were physicians talking about it to close to 94% of the time were physicians talking about it on a regular basis. So as we talked about initially, one of our roles is to say, boy, we need to make sure that families not only are aware of this, but also after they're aware, how can we make sure that they're changing their behaviors? So next slide. So in our second wave, we said, you know what, we're asking the same questions at multiple visits. How can we, assess, well, if we're continuing to assess this and we're having these recommendations, are families changing their behaviors? And so what we looked at was we had those two tools, and I'm going to show you that we'll break it down to the birth to 4 month and the 6 to 12 month tool in the bottom left corner. But you can see that in birth to 4 months, about 50% of families made at least one change in their behavior, and in the 6 to 12 months, close to 62% made a change in their behavior. And if you look in the bottom right corner, what's interesting is look at the changes in behavior that were made, and the majority of them were safe sleep changes, such as making sure that they didn't have crib bumpers, making sure that they weren't sleeping in a shared space, making sure that there weren't pillows, making sure that they were alone in a crib. So the recommendations by the pediatrician, not only now are we addressing it, but now families are going home and changing their behaviors based on our recommendations. Next slide. So then we said, well, you know what, maybe families aren't understanding. Maybe our tool just isn't reliable. So then we did some testing around tool reliability, and what we found was when the same individual answers the questions, the retest reliability was actually excellent for the single individual provider. We did find that when a different provider was answering the questions, that it wasn't as reliable. So the data which I showed you on our second wave was completely just the same individual, and that's where we showed the changes in the behavior. So the tool does work. It's reliable, but it's really helpful when we're analyzing behavior change to really look and make sure that it's the same person answering the questions both times. Next slide. So the advantages of the tool and the program that we're providing is, one, it targets specific risky behaviors for physician discussion. So it makes us more efficient. So instead of us having to sit there and ask them 20 specific questions and then discuss when we think that they've answered something inappropriately, have us talk about each one of those, that is really not possible during our 10-minute well-child visit. We actually now are giving them a tool, finding out what are the risks, what is the knowledge they don't know, and then we can actually fill those gaps, which is really what our job should be. The other advantage is that this tool is age appropriate for development at each well-child visit, so you actually don't have to think about what should I be discussing. It's right there in front of you. The scoring sheet is really easy. Matter of fact, after it's put into place, anyone could score the sheet within, it really takes probably about 30 seconds at most. And then we've supplied specific talking points for each question. So even if you're not sure what to say, these talking points will exactly tell you what to say based on what how the family responded. We also provide local resources, so questions like, hey, where should I get my car seat checked? Where can I maybe get a crib? Those types of things we actually provide as part of this tool and bundle. We also found that through repetition of topics, you yourself can actually even look at behavior change. So if you want to say, boy, am I making a difference, you can actually look and follow up with families, and you'll see that families are making a change in their behavior. Next slide. Really, in summary, I wanted to spend some time with you to say, look, keep injuries on your radar because it is the #1 cause of death for kids. Us as pediatricians, our main goal is to prevent morbidity and mortality. That's everything that we do. This is the #1 cause of morbidity and mortality, so we have to find ways that we address this efficiently and effectively. Us as pediatricians, we should be addressing this at every well-child visit. and we can be effective. We just need the right tools. And so hopefully you'll find that this tool that we've developed, it actually makes you more effective, it will make you efficient, and you will be addressing these issues such as safe sleep, so we can actually make a big dent and a bite in preventing infant mortality and these unnecessary infant deaths. But so what we're hoping today is, after hearing about kind of our tool, that you will receive all this, the information about where do you download to get the tool. You'll also get a screening, an answer key. You'll get the physician talking points, and then the method of what data you need to collect. And then after you participate, every physician that participates gets MOC for 25 points of credit, which will help with your maintenance certification, but also it will help you within your practice of being able to practice the best behaviors and be a part of this quality improvement work. Next slide. So we're hoping that everyone will enroll, and really you just have to complete the enrollment link and then log in. You'll receive an email within 5 days, and then you will then be a part of our prevention program, and you'll be putting it into place. And if everyone starts using this, as I said, especially in the settings where you guys are located, we can actually start to make a bite and prevent infant mortality.